and the title we landed on was Launching Cone Beam CT Technology in Your Dental Office, Part 1. Part 2 will be next week. And that title is our starting point, but I really want to make clear that, and we'll get to some objectives here, I designed this talk to apply to any dental office, whether you have a cone beam CT or not, or even whether you don't have one and never intend on getting a cone beam CT, or whether you are a specialty office. So really this is a general overview and what I consider ultimately kind of fundamental based knowledge for today's dental professional, whether you're the doctor or a member of the team. Because I think, as we've already all experienced, whether you have a machine in your office or not, somebody will come in with a scan on a disk or a jump drive, and you're going to sit there and say, well, what do I do with this? You know, does it work in my system? How do I open it up? Even if I have never opened one up before, and how do I make sense of it? Okay, so my goals really are to get you thinking along those terms, right? Whether you will intend to buy a machine or have one or not. All right, so on to our specific objectives. What I want to get to is really 3 fundamental ways we can view the data and advantages and disadvantages of each one of those. And then give you some encouragement and some strategies to, even if you don't have a machine in your office, to have confidence opening up that scan that the patient walks in your door with and making some sense of it. You know the anatomy, you learn the anatomy, and you're familiar with it. It's just a matter of commanding the computer mouse and the software to tell you what you need to know about it. And I think we can all get started on that fairly comfortably. I want to then segue into a discussion of some chosen scan factors as they relate to radiation dose and image quality, which is really something that dental schools are not teaching at all, but it's really fundamental to how you run the machine and order and choose. And then we'll segue that kind of into a discussion of relevant risks of x-rays and dental imaging. All right, so, and all this will set us up for a continued discussion next week. I'll also say that, you know, this is a really broad overview, and again, designed for any dental practice, specialty or general, and any member of the dental team. If you want more in depth of any of these topics, take a look at our other radiology CE offerings. My direct colleague Mansour Ahmad and I host a number of courses throughout the year. Our big one is a cone beam CT mini residency, where we cover all these topics in more depth, plus it's a day and a half of hands-on case learning, where you can really dive into this deeply. Very good. So let's talk about the cone beam CT first, and I'm gonna apologize now. We'll do a little bit of physics, but I will do my very best to make all the physics that I cover clinically relevant. So I'm going to first talk about what the machine is actually doing and how it's getting the information. And I'm going to jump through a bunch of points here and get to my skull. So this is our patient's head. And fundamentally, this is a lot like a panoramic unit, where we've got an X-ray source and a sensor, and that rotates around the patient's head. Very simple. And as it rotates, it takes a series of 2G projection images at a bunch of different angles. It might take hundreds of these 2D projection images. We'll call those basis images. All right, so here's X-ray source and receptor. It's going to rotate around the patient like this. And the basis images, the raw images, the data we get out of that looks like this. This is a scan taken from the raw data taken from a patient in our orthodontic clinic. And from these images right here, basically some fancy mathematics and software takes over and computes our 3D information. And that is fundamentally built up of a stack of something called voxels. So we'll talk about those, okay, in a moment. When we actually get the data out, it looks like this. Okay, so this is our volume rendering here. And each little component of this is called a voxel. If you're familiar with a pixel, on your digital photograph or your computer screen or phone screen. Picture really stands for picture element in a 2D digital image. Well, if we talk about a 3D data set, each single element of that is excuse me here, a voxel, a volume element. Okay, so if we fundamentally look at this data set, there are three main ways to view it, right? Slices, volume renderings, and reconstructed radiographs. And I'm going to take each one of these in turn and talk about positives and negatives, or advantages and disadvantages of them. So first, slices. Slices offer the most accurate and most detailed views of the cone beam CT data, okay? But I'm going to point this out here. We'll discuss this coming up. You're taking a 2D slice of the data. It's easy to get lost, okay? And the way to get lost or keep bearings of yourself is to use your crosshairs. These slices, they're dimensionally accurate, right? But you have to keep aware of your slice orientation, and I'll comment on that in a few slides as well. So let's look at some images. If you open up any reasonable cone beam CT software, one that comes with a machine you may own in your office, or one that comes with a patient on a disk or a jump drive, you'll probably see a view called multiplanar reformatted, or MPR, where you get standard anatomic planes of axial, sagittal, and coronal. Okay, so it looks something like this. All right, here we've got an axial view. By convention, most softwares will view that from the toes up. You'll get a sagittal view from the side and then a coronal view from the front. Okay, so this is called MPR, and it's a very standard approach to reviewing a data set. It's what I use as a radiologist to review the data set top to bottom, front to back, side to side in a comprehensive manner. And when I say crosshairs, here are the crosshairs I'm referring to, right? Most, if not all, reasonable cone beam CT softwares will have some sort of lines on them. They're not always going to have colors like these ones, but they will be there. And you can use them to your advantage to keep track of where you are. Now, most of us here, I would hope, can recognize that we're somewhere in the maxilla of this patient. Okay? But if you really want to know exactly where this slice is coming from, you can look in the other views and find this orange line right here in an axial orientation and say, aha, all right, that line right there. And I'm just going to check a quick text here, chat. Cool, good, we're all good. All right, so this line right here tells us the exact location that this slice shows up. Similarly, if I want to know where this coronal slice is coming from, I can look in the other views and find this purple line here that's in a coronal orientation. And this line right here is going to tell me exactly where this coronal slice is coming from. Okay. You can use these dynamically in the software. In my slide here, everything's fixed, but what I can do in the software is pick these up and move them around and scroll it up and down and side to side. And if I want to know, cut right through the teeth, I pick this line up and drop it here and look up in this view and know that I'm going to be cutting down the axes of these teeth. They all cross-reference each other, in other words. And that's what I mean by when lost, use your crosshairs. You can keep yourself from getting totally lost in the anatomy. Another thing too is any reasonable cone beam software, regardless of brand, will give you little clues. R and L for right and left, P and A for anterior and posterior, of course. Use those to your advantage. And like I said earlier, most cone beam softwares and radiology softwares by convention will view the axial view as the patient from the toes up. That's not always the case. There are a couple exceptions out there. In that case, the R's and the L's would switch, which will help you out. Okay. So you're not limited to those three views, axial, sagittal, and coronal. With some simple tools, you can start to create something called custom sections or non-orthogonal slices. They have different names. But here's an example of one where I've got my standard 3 anatomic planes, but I've taken a tool and drawn this yellow line here down the length of the mandible, and it gives me this custom section right here. You can draw these in any which way you want. So if there's something specific you want to look at, for example, the canal space in this particular slice, you can do so, which is very helpful. And again, you're not limited to these. Again, my principle, if you're lost, use the crosshairs. If I want to know where this slice is, it turns out it's the exact middle yellow line in this triplet of 3 lines in this particular software. It exactly references it. And then dynamically in the software, I can pick this line up and move it around, and this slice will update accordingly. Okay, so that's MPR views. Before I move on from this, again, I'll reemphasize that you can take that CD that comes into your office or open up your brand new cone beam CT machine and find this view. It's many times going to be default. They're one click away, and start to scroll through your patient top to bottom. And that's the best way you can review everything front to back, top to bottom, side to side. And we can discuss a little bit more about that review next week. Another really common way to review the cone beam CT dataset is with something called arch sections of your jaws, the maxilla and the mandible. And they'll look like this. And what I'll point out right now is what looks like a panoramic radiograph. It's a simulated or reconstructed radiograph in this case, and we'll cover that shortly. But what I get from it is another axial view here. This is just like the axial view in our MPR view we just covered. Turns out that that axial cut is right from along this orange line here, exactly. You can see we've got a couple impacted canines, and I'm seeing them right here and here. So again, this exact line tells me exactly where this slice is coming from. But on top of that, you'll notice I've got 5 green lines right here. And those 5 green lines I can move around. They're going to give me 5 individual slices here that run buccolingually through the arches, which is a really, really convenient way of looking at all the teeth. It's how we think about teeth. We don't necessarily always think axial, sagittal, coronal as dentists. We think more mesial, distal, buccolingual, which is what these slices are going to give us. And again, my principle, when lost, use the crosshairs. If you just look in any software and start looking for the lines, there's these 5 lines here. They give you exactly these 5 slices right here. This particular green line here is giving us this particular slice with the crosshairs through it. And you'll notice also on top of that, in addition to some R's and L's for rights and lefts, I've got a numbered scale on this software here, which is the same number scale here, and then each one of these images has a number 98, 101, 104, 107, etc. They correspond to these numbers here. So just by paying attention to a few details in the screen, it's fairly intuitive to figure out what exactly you're looking at. And then it gets even more intuitive when you can grab this with your mouse or with your scroll wheel, start moving things around, and these all update. It's very dynamic, it's fun, and I love it. Very good. You can do this also with the TMJs. So a surgery office or an orthodontic office or an oral facial pain office can set up custom sections of the TMJs. They look like this. Same principles apply. You've got green lines here. Turns out we've got 6 of them on each joint, and it gives us these nice slices coronally through the TMJs of this very healthy patient. Okay, so that's slices. Bottom line, it's the most accurate and the most detailed view of the information. And if you're going to be reviewing that information and getting all the information you can from it, you have to be looking at the slices. The downside of it is it's easy to get lost. Okay, so you need to look at your crosshairs, practice that mental gymnastics, know your anatomy, and dynamically work through those slices to know what you're talking about. The next way to review this cone beam CT data, and again, this is independent of software, independent of machine maker, is with volume rendering. So it looks like this here in this particular patient who's getting planned for implants 7 and 10. These can be solid or kind of a semi-transparent rendering of the patient in 3D. This one being semi-transparent, where it looks like you can see the teeth inside the bone, which is kind of convenient. The strength of this particular view of the data set is it's fantastic for getting your spatial relationships and assessment of those maxillofacial structures. So if you have a patient with a lot of pathology or a big asymmetry or an impacted tooth, the 3D rendering is a great way to wrap your brain around that whole pathology or phenomenon. It is dimensionally accurate. So if you're looking at this, there's very little distortion. The accuracy on some cone beam CT scans gets down to 1/10 of a millimeter, maybe 2/10 of a millimeter or so, once we account for all the kind of fuzziness and a few minor artifacts. And these renderings, they are accurate. However, the tissue that you actually see presented is not always representative of exactly how much tissue is there. Or in other words, something called threshold settings, which I'll explain in a moment, can really influence the appearance of those tissues. Okay, and because of that, this 3D rendering is not reliable to assess the fine bony details and bone quality. If you need to do that, you need to go back to the slices. That's going to be the most accurate representation of the actual scan data. Okay. So let's talk a little bit more about threshold. Here's a scan with a fairly optimal threshold. Just by changing one arbitrary setting in this software called threshold, in other softwares it's called brightness, I can make the patient look like they're losing bone or growing extra tissue kind of clouded around their face. Now what's actually going on is the software is taking a guess at what it thinks is bone and what it thinks it's tooth, and also what it thinks is soft tissue and air. And most of the time it gets close, but as we'll see in a little bit, the data isn't perfectly accurate, so we can't get a perfect rendering out of these scans, and you have to live with the best you can get. Right? And I actually think that's just as important as recognizing normal anatomy and pathology in reviewing one of these scans, is also recognizing what the limitations of the data are. Threshold setting limitations are one of those things you need to recognize and appreciate. Okay, so again, great for assessing kind of where things are in the patient, but if you need to look at details, you must go back to the slices. Okay, our third way to review the cone beam CT data set are with reconstructed radiographs. And I showed you that pan earlier, and I mentioned this. But what we can do from the data set is reconstruct pans. And if you're in an office an orthodontic office or surgery office that'll deal with cephalometric tracings, you can also reconstruct lateral cephs and even PA cephs. So the whole reason we do these is they are great for quick overviews. And then again, if you're doing the cephs, cephalometric analyses. I really believe that dentists love panoramic radiographs because you get all the teeth and the supporting structures in one view. You can leave it up on a monitor in your operatory and have basically a roadmap for your patient's dental presentation. It's extremely convenient. And that is why commonly, 100% of the time in my case, I reconstruct a pan from every single cone beam CT scan. Okay, it lets me use it as a roadmap to evaluate tooth by tooth. So let's talk about that, kind of the strengths and weaknesses here. The weakness is that we lose detail once you reconstruct out from the data set into a radiograph. You get some extra blur, and you can actually introduce some distortion stuff. We'll talk about that in a moment. So again, if you have to see the detail, if you're assessing bone quality, you must use the slices. Okay, here's an example of a reconstructed panoramic image. It looks nice. There's no spine shadow or ghost artifacts, which is really convenient. You can, and once I'll rewind here, go back to my cross sections. Once you have this reconstructed pan, you can use it as your roadmap and take this green line, drop it say I want to look at tooth number 30, drop it here on tooth number 30, and then once I go look down here, I'll know that I'll be cutting through tooth number 30. Right? So it's your reference point to keep from getting lost. It's fantastic. Okay? But again, you lose a little bit of detail. If we go back to this reconstructed pan right here, a sharp eye will tell you that this image is kind of blocky or blurry. You actually have a slight resolution penalty when you reconstruct a pan from a cone beam CT compared to a traditional 2D pan. To that I say, I don't care. Right? I don't need to scratch my head and wonder what's going on with the PDL lamina dura around the apices of these teeth on this reconstructed pan, because I know I have the 3D data set behind this, and I can go look on the slices where I get a lot more detail and 3D detail to look at these. So use this as your roadmap, as your reference point, and then look at the slices for the detail. Here's a reconstructed ceph, and I know I see a question about a ceph coming up, so we'll get to that once we wrap up here. Okay. There is a little bit of blur introduced them. There also, you can introduce distortions once you reconstruct a radiograph. So if you have to make accurate measurements, that really needs to be in the slices. Okay, and just to give you an example of how that can occur, and I'll pause for a moment and really talk for a second on how we reconstruct these pans. Fundamentally, all you're doing is drawing in a horseshoe shape into the patient's scan. So here I've got a horseshoe shape sitting around the jaws. It's actually kind of forward in front of the teeth. This particular image here, I've got the same horseshoe shape sitting behind the teeth. Now, in a perfect world, I'd have it sitting right on top of the teeth where I'm going to get an ideal pan. And all the software is going to do is sum up the tissue that's inside of these lines and create this virtual slab radiograph. Now, just like in middle school geography, when you're learning how to map the globe, by taking a curved structure with dimension and flattening it out onto a 2D image, you fundamentally introduce some distortions. Right? So, and because of that, your measurements on a reconstructed pan in cone beam CT are not always accurate, even though the raw data, the 3D data, is quite accurate and non-distorted. You can also make it worse, again, like my images here, if I start to draw the horseshoe in the wrong shape. So this one being too far forward, we start to distort these front teeth and angles a little bit. They look fat. Right? If I draw the horseshoe shape or this focal trough, I'll call it, too far back, the front teeth become shrunk, minified. This is actually a lot like placing your patient in your traditional panoramic machine in the wrong spot. You can create all these wild distortions just from poor patient positioning. You're just doing it virtually here with the cone beam data set. Okay, so again, summarizing our pans, use them for your analyses and your roadmap or your reference point, but remember that you can introduce some distortions and lose some detail. If you have to see the detail, go ahead and look at those slices. Now, a couple other notes about opening up these scans with confidence, as I call it. If you have a disk or you have a jump drive, plug it into your computer and find something that says .exe or run me or start me or auto launch and click and go. You're not going to hurt anybody. That's the best news about imaging, is if something gets screwed up, you close it and open it again. And then just play. See if you can work your way through moving some slices in the MPR view. See if you can reconstruct a pan. Sometimes softwares will do one in a semi-automated way. That works some of the time, sometimes most of the time, but I would encourage you to go find the tools, and they're fairly easy to reconstruct and manipulate your own pan. In other words, you can customize these very quickly. It takes about 10 seconds or less once you get adept at them. And so you can start to reconstruct your own pans. And from there, you can review and cut through all the teeth, kind of look tooth by tooth. All right. I'm going to leave those 3 ways to view our data set, check the time here, and talk briefly about artifacts. And first I'll define like a textbook definition of artifacts is any distortion or corruption of image information that misrepresents reality. And I start with this really boring textbook definition because really I think it's important to understand from an imaging philosophy perspective why we do imaging. And the whole reason we do imaging is to tell us things that we can't see clinically. That's it. The problem is that every single imaging tool we use, whether it's a bite wing or a cone beam CT or a pan or even an MRI, has imperfections. They are never perfect. They never tell us everything accurately and exactly the way it is inside the patient. And any of those deviations are artifacts. And so recognizing those limitations is extremely important in my mind so that you can acknowledge, yes, this is what this image is telling me, but also, yes, this is what this image can't tell me. Okay. So in terms of cone beam CT, there's really two main ones that we need to recognize: patient motion artifact and something called metal streak artifact. So I'll define each one of these and then show you some pictures. Let's talk about patient motion artifact first. What you're going to see is a double contour or excessive streaking at osseous or tooth boundaries, so hard tissue boundaries. If you put a patient in a cone beam CT machine and they move a lot, the scan is going to be a mess. You're going to know it. And most of the time, your staff will see them because they're monitoring that patient during the scan. They will see them move and most likely elect to retake that scan. What I'm talking about here is minor motion. The ways to control that are, of course, patient education, stabilization. So if you have a cone beam CT with a strap or some sort of head stabilization restraints, use those. And the sneaky strategy is using faster scan times. You can adjust those on cone beam CTs. And what I mean by that is if you have a little kid or an elderly patient that can hold still for 10 seconds, but they can't hold still for 30 seconds, select the 10-second scan. We'll see in a little bit, there's an image penalty that you get, or image quality penalty you get by selecting the faster scan time, but if the patient doesn't move, you're going to come out ahead. Okay, pictures. Here's an axial slice, and what I want to point out is off the corners and edges of teeth, there's all these streaks, and it actually looks, if you look closely, that all these teeth are kind of disjunct from each other. This is a very slight patient motion, which I think is important to recognize. Now, if you're taking this scan, I'm going to get ahead in my thinking a little bit, and this will come back in a number of slides. But if you're taking a scan just to look at where a tooth is, orientation-wise, so you have an impacted tooth, and you can find it on this scan with motion artifact, you're done. You do not need to retake the scan. But if you are an endodontics and you need to find a missed canal, or you're suspicious of a root fracture, or you have some piece of pathology that you need all the detail you can get, you are not done and you need to go retake that scan. Okay, here's another example, and this is what I mean by double contouring, where the patient shifts just a little bit during the scan, and you'll see it looks like there's a second bone set up right next to the first. They've shifted, and you can appreciate that double contouring here. You can even catch a hint of it in the patient's spine in this particular scan. So this patient moved a little bit. And again, if you just need to figure out where an impacted tooth is, or the very rough estimates of alveolar height and width for implant planning, you're done. But if you need to see something small like a missed canal or a suspected fracture or pathology, you're not done. Right? Or even if you're doing guided surgery where you need to verify that you and get a very nice fit of a guide to that scan later, you're not done. You need to go retake that scan. We'll talk more about how to think about ordering later on. The second main artifact I want to review is something called metal streak artifact. And that is caused by X-ray's inability to fully penetrate metal and other very dense materials. Okay. So I'm going to spare you with the physics. We could talk all night about what's actually happening there. We won't. But what you get at the end is this combination of light and dark streaking artifacts that surround these very dense objects. So let's look at a picture. Well, first I'll tell you, you need to remove what metal we can. We all know that as dentists, we like to put a lot of metal things in people's mouths. Many of them are very difficult to remove. So if you have a removable partial denture or something like that, or an orthodontic appliance that can come out for the scan, take it out. But if it has to stay, we'll deal with it. The good news about streak artifact is it's confined typically to the axial plane of acquisition. So it's really confined, and I'll show you a picture right here. All this smudginess is our metal artifact. This is corrupted data and we can't get rid of it. And this streaking here in the axial view is artifact. It typically gets confined to this horizontal plane. So once you get below it or above it, you're typically good. Now, some cone beam CT makers are advertising and promoting some metal artifact reduction approaches. There's validity to those. What they can do is reduce some of the smudginess here, but what they're really not doing is reconstructing the raw data properly. And also what they can't do is get at what I call some of these near field artifacts right next to the metallic objects. That data is corrupted and lost. And at this time, we can't fully calculate for that loss of information. So we just have to deal with it. All right, let's talk about dose. And I'm going to try and achieve a number of different objectives all at once. So here we go. I want to talk about dose related to some chosen scan factors, and then segue that into a discussion of relevant risk for our patients. So the first argument I'm going to walk you through is that our dose that we impart to the patient with a cone beam CT scan, or any X-ray based imaging for that matter, is based on three chosen scan factors: field of view, how much tissue we're scanning, resolution, and then something called noise, which is largely driven by scan time. If you go from a 5-second all the way up to a 30-second scan, that's what I mean by scan time. So let's take each one of these in turn. First one, field of view. We can really break down available cone beam CT machines into kind of 3 field of view categories, and I'll get pictures up here. The small ones are around 5 by 5. I'll call those dental. Medium would be just the teeth, or dental alveolar. They're anywhere from 8 to 8, roughly to 10 by 10 centimeters. And then large, or maxillofacial, where you're getting the joints and parts of the skull base, or even the whole entire cranium. By the way, for those of you who are maybe thinking about a cone beam CT, interestingly, this is where I see most offices make mistakes, is getting the wrong field of view unit. If you're in orthodontics or surgery, or looking at the joints, you need to be up here in the large here. If you're just doing implants, you probably need a medium. If you're just doing endodontics, you need a small. We'll build on that discussion, or I'll build on it right now, and say that if you're doing endodontics, you pretty much need a machine that will get down to a small field of view, because with that, you can get a higher resolution scan compared to some of these larger ones. Now, I'll come back to my point about dose later too, but I'll tell you right now, this is fairly intuitive. In general, the more tissue we scan, the more dose the patient gets. Right? So not a lot of dose here, more dose as we get to the larger field of view. Our second scan factor that relates to dose is something called resolution. And I mentioned voxels earlier, which we can think of as our 3D pixel. In available cone beam CT units, they range, our voxel side of that cube ranges anywhere from 0.5 millimeter down to less than 1/10 of a millimeter. So pretty darn small, really. Now the trend is, typically the smaller the field of view, the smaller the allowed voxel size. So I've got a picture here of a scanned phantom skull where we've got images from 0.4 down to 0.2. We won't be talking about sharpening much, but I just bring this up because even at 0.4, you can see things like canals fairly nicely. I want to re-emphasize this point right here. The smaller the allowed smaller the field of view, the smaller the allowed voxel size. That's this unit right here. So with this small field of view 5 by 5 unit, a lot of times people will call these endo units, you can reach this sub-10th of a millimeter resolution size, which is really useful for looking for missed canals, fractures. You still won't see them, but we can spend a whole nother course, talking about fracture imaging. But if you were to try and look for those features on a larger scan, you might only get to the zero point 0.2 or 0.15 voxel size at best and miss some of that detail. We'll come and talk about that small high-res scan in a little bit. Okay, and again, if we relate this discussion to dose, the higher the resolution you're going to image at, the more dose you need to use to get there. Okay, so that's our dose tie-in with resolution. The third factor I introduced was something called noise, and you're probably not familiar with noise, so I'll define it. Our boring textbook definition is it is a statistically random variation in voxel grayscale value that typically comes from, the most part, X-ray photons that interact in the patient and bend, of course, they scatter. And some of those, when they interact in the patient, they come out sideways. Some of them turn around to 180 and head back towards the X-ray source. But a few of them bend just a little bit and accidentally hit the detector. The detector is not that smart. It can't differentiate between an X-ray photon that went straight through the patient and is important in image formation, and those that interacted and should have been absorbed or scattered elsewhere, but actually hit the detector. And that incorporation of those scattered photons creates this statistically random signal intensity, if you will. And we see that as an image phenomenon called noise. We can't get rid of it fully with available technology. We can model it and then subdue it a little bit, which is great, but we can't fully avoid it. It is a phenomenon relevant to dose. Okay, so I want to show you some pictures first here before we tie dose in. This is a noisy scan right here. If you look in the soft tissue, it's speckled, they're grainy appearing. If you look in the bone, even the cortical bone, aspects of it look speckled or grainy. That is all incorporated random signal intensity from scattered photons. And to show you more images, here are two images of similar anatomy taken on the same machine, same resolution. So both of these are 0.3 millimeter voxel size. This is a high noise scan. It looks pretty crummy and grainy. This is a lower noise scan. And you can start to appreciate some details. Okay, like this cortical plate up front in the lamina dura. That's pretty tricky to see on this scan. Now, you might guess the key difference between these two scans was dose. This was fairly low dose. We ended up with a noisier, I'll say, uglier looking scan. This is a nicer looking scan, but we had to use quite a bit more dose to get there. Okay, now I'm jumping ahead in my thinking, but we'll come back and I just want to remake these points because I think they're very important. Is if you have a scan like this and you just need to see where a tooth is, say you have an impacted tooth or you're in orthodontics, this scan is perfectly adequate. You've used just as much dose as you need to, nothing more, and you have the information you need. If you are in endodontics and you're looking for small canals or you're planning a guided implant surgery, you may need to elect for a lower noise scan, a higher dose scan to get that accurate image detail. Very good. So a few more comments about noise. Really, noise is one of the reasons why cone beam CT is unable to differentiate different soft tissue types and soft tissue versus fluid. I haven't made this point yet, but I'll point out right now that compared to, for example, medical CT or MRI, where you can differentiate muscle versus fat, versus even in the brain, gray matter versus white matter. We can't do that on cone beam CT. And noise is the primary reason there. It washes out all those soft tissue differences. It's even worse than I'm describing because we really can't tell the difference between soft tissue and fluid on most cone beam CT scans. So if you're thinking clinically that you need to figure that out, you need to be ordering something other than a cone beam CT. What cone beam CT does do very well is give us fairly high resolution imaging of hard tissue. So that's bone and teeth, something we're very interested in dentistry, so it's convenient for us. Also, because of noise and a few other factors we won't cover, it means that our grayscale values and even of bone vary somewhat throughout the scan and are unreliable for anything more than an estimate. That means, one, our renderings look crummy. That's why our threshold settings aren't always perfect, like we described a number of slides ago. It also means that if you see in a software a number reported called Hounsfield units or even approximated Hounsfield units, Hounsfield units are a specific number tied to multi-detector, or what we'll call medical CT, that are accurate in that imaging system. In cone beam CT, they're not quite accurate. They're a ballpark figure. So much so that I really feel that with your eyes, you can tell just as accurately what kind of bone you're looking at, as opposed to any other numbers. And I mentioned this already, okay? Because of noise, our 3D renderings sometimes look unreliable. It makes it look like there's bone there when it's not, even if you feel like you have the threshold setting as good as you can get it. And again, I've covered this. That cone beam CT really does a nice job of high resolution, dimensionally accurate imaging of our higher tissues. It also does a really pretty nice job of our soft tissue to air interfaces. So that's skin to air and our airway passages to air. Here's our poor rendering right here. It looks good in the anterior jaws, but once we get back here, the bone looks eaten away. That's not actually the case. If we looked at the slices, it would be there, but really because of noise, we're losing that signal. All right, let's start tying this together. Noise is probably the most significant factor influencing our perceived scan quality, followed second by resolution or voxel size. And so what that means is if we have a very noisy looking scan or noisy scan, it looks bad, right? We'll call it a bad looking scan. But I've hopefully alluded to, I don't care if a scan looks bad or not, and we really shouldn't as dentists. You have to think about your diagnostic goal or your diagnostic purpose for what a scan should look like, because we have this dose component tied in. Or in other words, desired scan quality really has to be dictated by your diagnostic goal, not the desire for a nice looking image. That's very important. We can control the level of noise in many machines, mostly by scan time. Okay, selecting how long we let that machine run. And in many other machines with high definition modes, or sometimes they're even called endo modes. Okay, so we'll talk about that in a week a little bit more in depth, but if you let that machine run at 30 seconds, you're going to get a lower noise scan. You're going to use more dose to get there and impart more dose to the patient and have a nicer looking image with more detail. If you have a very quick 5-second scan, you're going to have a lot of noise, but you're going to get away with a lot less dose. Very good. So let's talk about really what dose means. It's ultimately a measure of the ionizing radiation imparted to our patient. And the single relevant concern we have in dentistry is risk of additional cancers later in life. If you read about radiation biology, you'll read about hair loss and skin redness and cataracts, a number of other really interesting biological effects. None of those occur in dentistry because they happen with a different biological mechanism that requires a threshold dose to be met, and we don't even come close to reaching those thresholds in dentistry. What we do have a risk of is cancer later in life. And again, it's related to our scan field of view, resolution, and noise. We already covered this, so of course, if you're scanning more tissue, you have more dose for the patient. But for the remaining factors, you really get to pick two here. So if you want a low noise scan, you either have to pick a low resolution or a high dose. That's how this kind of diagram works right here, pick two. I think about it a little more clinically, where if I'm plugging in the numbers for my machine and I have a young orthodontic patient that is a little more radiosensitive, which we'll discuss in a moment. And all I need to do is figure out where the teeth are, or where an impacted tooth is, or where the jaw structures are. I should be putting up with a noisier scan, with a quick scan time, and pushing a lower dose to that patient. I get the image quality and information I need from that low dose scan. Conversely, if I have a patient, an adult patient, who's in pain and I'm suspicious of an endodontic concern, a missed canal, or a root fracture, I need to get as much image detail as I can out of that cone beam machine. So I'm going to pick a long scan time, as long as I can, turn on the high definition mode, and get at the highest resolution I can. What I'm going to impart is basically as much dose as that machine will allow me to impart to the patient, but in return, I'm going to get the highest image quality possible and have the best chance of picking up that small root fracture, or that small missed canal, or that small piece of pathology I'm looking for. Those two clinical scenarios are a nice construct to start thinking about what buttons you need to push on your cone beam CT, regardless of brand. Okay, now let's talk about dose and context, and I'm going to relate it to risk. So what I'm going to talk about is the average American citizen for a moment here. And for any average American citizen, I will state that half of our annual exposure to ionizing radiation comes from natural sources, and most of that is radon, the gas that bubbles up in your basement. The other half comes from human-made sources, of which about half of that comes from medical CT. Notice I'm not saying cone beam CT here. And if we look at dentistry as a whole, all X-ray use in dentistry contributes at most 1% or 2% to that annual exposure. So here's the pie, if you want to look at the pie. This is the average annual exposure for the average American citizen. About a third comes from radon. Medical CT is about a quarter. You can look at the other pieces, but here's dentistry, 1, maybe 2%. So we're a pretty minor player. Now, let's tie dose to risk. And again, I stated earlier that our main and only relevant risk for use of X-rays in dentistry is risk of cancer later in life. So let's take our same average American citizen. Our total lifetime cancer risk is 20 to 40%, which is a pretty staggeringly high number. And if we select from that and look at what number of cancers come from ionizing radiation, it contributes less than 1% to that 20 to 40% estimate. So in other words, if I took away all sources of ionizing radiation, natural and human-made, I'd go from a 20 to 40% cancer risk estimate to 19.9 to 39, or sorry, 19 to 39. So it's not a huge change. Or in other words, ionizing radiation is a pretty weak carcinogen. And then remember that dentistry contributes only a couple percent at most to that less than 1% added cancer risk. So it really, according to the numbers, dentistry is a minor player. But there's always a but. As a profession, we perform enough dental radiographic exams that our use of X-rays actually does contribute to a real number of cancers. And from a public health perspective and an ethical perspective, we should really be avoiding those. Right? We don't want to cause excess and unnecessary cancers. And we can look at this best estimate here where we consider 0.055 additional cancers per sievert of dose. We'll dive into that number in a moment here. And I'll point out also, I alluded to this in a couple of slides ago, our pediatric patients are anywhere from 3 to 10 times more sensitive to ionizing radiation than adults. So our pediatric patients need a little extra care. Okay, so let's look at the numbers. If anybody really wants to nerd out on this and read some of it, I will tell you that you need to be looking for numbers reported in units of sieverts, or commonly microsieverts, which is a measure of effective dose. Be careful because there's some other really similar sounding terms like equivalent dose and exposure that means something very differently from a radiation biology perspective. You need to be looking at effective dose numbers, and that's in sieverts or microsieverts. And the reason I picked this specific unit is it's probably the most useful way to compare risk of cancer from different X-ray machines and sources of ionizing radiation. So let's look at a table here, and I'll point out the column on the left side here and here, which is some common dental radiographic exams. The middle column is where we'll focus first. This is effective dose in microsieverts. And I'll point out our cone beam CTs. Right here, they range anywhere from kind of 10s, 20s up to 1,000 or so at most. So they're medium to high. They range a lot because of the factors we just discussed: field of view, resolution, and scan time, which ultimately influences our noise or image quality. Compared that to a pan, and cephs, those are single digits to 20s, so these are quite a bit lower. Compared to a multi-slice, or we'll commonly say medical CT, they're anywhere from about the same range of a low-dose protocol up to much higher, almost 1,000 to 1,500. If we look at some other intraoral exams, you can have comparative numbers, and for the sake of time, I'll just point out a couple interesting ones here. Just by going from round collimation to rectangular collimation, if we take our full mouth series here, for example, you can cut your dose down quite a bit. So if you're very serious about sparing dose in your office, be serious about using rectangular collimation. Okay. Now, those are the numbers. What I want to focus on the right here is our probability of X in a million fatal cancer for an adult. Now, how to interpret this column is, for example, if I myself get a panoramic radiograph, I have a 1 in a million chance of getting a cancer from that pan. Or if I have a small field of view cone beam CT, I have a 1 in 40 chance in a million of getting a cancer from that cone beam CT. That's how you interpret this data. Now, this is useful for us as professionals to think about the numbers. It's a rare patient who wants to hear that, oh yes, patient, your pan today will give you a 1 in a million chance of acquiring a cancer. I know these numbers and I still don't want to hear that. What you need to start to think is a comparative risk rather than an ultimate risk. And so very motivated patients, some that end up in my office from our school clinics who are very concerned about dose, I'll start to share with them some of these numbers, where I ultimately say, ultimately by coming here to our school, you assumed a number of risks. So just by walking around our planet, you have a number of risks that you assume any given day. And we can compare them to our imaging with a table like this, which is comparable 1 in a million risks of dying by activity. So what this means is if I ride my bike 10 miles, I have a 1 in a million chance of death by accident, or even 6 minutes by canoe, right, death by accident. There's some other interesting ones here. Flying 1,000 miles by jet, you have a 1 in a million chance of death by accident. Flying 6,000 miles by jet, you have a 1 in a million chance of acquiring a cancer due to that additional cosmic radiation you received at higher altitude. So this table is kind of darkly fun here. And I bring it up as really a reference in saying our risks are low. We assume risks every single day of our life, and the dental radiation risks we assume in our offices by ordering X-ray imaging for our patients is also low. My best advice for what to tell your patients and how to train your staff for how to talk to patients about dose is acknowledge that there is a risk, yes, but also explain that it's extremely low. We've selected the lowest, most dose-efficient machines and protocols to give us the diagnostic information we need to decide your treatment. And the risks of not obtaining that information in terms of additional possible infection or complications of treatment vastly outweigh the small added risk of cancer. that statement there, or a variation of it, satisfies most patients. Again, it's the rare patient who wants to dive into some of these statistical numbers. If you really, really want to dive further in the numbers, if you have a machine and want to look up exactly what you're doing with each protocol, you can probably find it. So there's references out there. And this might be useful if you're deciding, hey, if I choose the 20-second scan versus the 30-second scan, how much dose difference does that make? You might feel surprised by a jump in dose, or you might feel comforted by a marginal jump in dose. And anybody can email me if they have interesting questions about that. Okay, here's where it all comes together. When do you acquire an image? Well, first, at least in the state of Minnesota, you have to have a written prescription for that radiographic image. That's a legal requirement. But in terms of our thought process, what I want you to ask yourself, and this could be a cone beam CT, could be a bite wing, could be a pan, could be anything, is if I acquire that image and learn something, will it change my treatment plan? If the answer is yes, go ahead and get that image. End of story. If the answer is no, you maybe don't need that image. And commonly, they'll fall back on this one. Well, I will get an image of this particular patient and it might change my diagnosis. If it still means I'm going to do the same thing, meaning it does not influence my treatment plan in either way, that image isn't worth acquiring. Okay, so just changing a diagnosis alone is not a reason to acquire a scan. It has to influence your treatment plan or help you make a treatment decision somehow. These other questions up here, will it change my patient outcome or will it benefit society, are important questions. This is really what we should be answering here is, say, for example, ordering cone beam CTs on every single implant patient. Does that improve our outcomes and benefit us as a society? The answer should be yes to both of these, but to figure out that answer accurately requires some fairly sophisticatedly designed research studies. Couple other perspectives I want to introduce is I hear a lot from people say, well, I'm just so much more confident if I have that cone beam CT scan. And that's why I order it. And I say, well, careful, because I've met some fairly timid clinicians who are fantastic and some fairly confident ones who are not quite fantastic. And so if you're asking yourself this question, you really should be thinking back to, am I confident in my treatment plan decisions, even the nuances and what might influence slightly a small decision in my treatment plan? And then also, is it making my patient outcomes better? Right? Is that adding to my confidence? I've also heard the perspective, well, I order the scan because it's an exceptional patient education tool. It truly is. You can explain a complicated scenario to a patient with that 3D base set. But that reason alone is not a reason to order the scan. You have to be, again, asking yourself here, will it change my treatment plan? So this is all kind of more on the philosophical end, and we'll be building on some of those choices and specifics next week a little bit. Okay. Here, I want to try and, again, tie it together a little tighter. If there is a diagnostic need for that 3D information, go ahead and order the scan. Same thing with a bite wing, same thing with a pan. The principle is the same. All right, again, is it going to influence your treatment plan? If the answer is yes, go ahead and order that scan. If it's not, don't order it. It's as simple as that. You do have to prescribe radiographic exams with care, again, because there is, even though it's low, there is a risk, a cancer risk associated with use of x-rays. So adjust your scan field of view resolution and scan time to meet those diagnostic needs. Now we'll build on this next week as well into some more specific numbers. But again, keep in mind my young ortho patient where all you need to see is where the teeth are. You can put up with the noise and use a lower dose scan for that more radiosensitive patient. Compare that to the adult patient in pain who you are suspicious of an endodontic problem where you need as much detail as you can to find a suspected missed canal or fracture. That patient, you are justified in getting as high image quality as you can using as much dose as the machine will let you to do it. Okay. What I'm ultimately saying is your scan quality has to be dictated by your diagnostic goal, not the desire for a nice looking image. And again, remember our pediatric patients need extra care. They're anywhere from 3 to 10 times more sensitive. All right. I'm looking at the time and I'm at 8:01 exactly. I'm just going to briefly introduce the objectives for next week. Is we're going to build on this discussion of when to order a cone beam CT scan and specifically how, right here, kind of what buttons to push, resolution, scan time, field of view, etc., for different scenarios. We'll dive into the basic strategies and responsibilities of image interpretation. I alluded to a little bit of that in kind of how to use the slices, how to use the MPR view, and how to use that arch section view tonight. We'll build on that discussion. And then I'll wrap up next week with a discussion of the best imaging practices for implant treatment planning. And with that, I'm going to try and answer a few questions here. So Dr. Schiffman, who I know, asks me, what imaging, if any, is needed to evaluate a symptomatic TMD patient at the initial consultation before any treatment has been implemented, including home-based self-care? Oh boy, Dr. Schiffman, it's great to hear from you. To that, I would say if you as the clinician feel that you're suspicious of anything going on clinically that could uh, uh, change your initial treatment plan, you should be looking at imaging. So that might be a disc issue. The most obvious one I can think of as a radiologist, and again, I will say that I am not a TMD and orofacial pain specialist. I work with them closely, but I try and support them from an imaging perspective only, is if you are suspicious of a rare joint neoplasm or significant loss of vertical height due to advanced degeneration, that can be a strong indication for imaging. From the technical perspective, you can lean on, if you need to see hard tissue things, go with cone beam CT. It's just as good as medical CT. If you need to see soft tissue and specifically the disc, you have to be looking at MRI. So Dr. Schiffman, you and I can discuss that more at length at another time if you'd like. Next question I'll answer is, can we do lateral cephs if I have a cone beam? The answer is yes, absolutely. It depends on the capabilities of your software. So you really need a software with that functionality built in. It also depends on the field of view that you order. So typically with the lateral ceph, you're getting a large field of view. There's software packages where you can do some really fun, interesting things where you can mimic or simulate the divergent beams in a traditional ceph, where one side of the face is slightly more magnified than the other. You can also eliminate that and basically create a perfectly ideal beam that eliminates that magnification. Either of those, it's fairly well documented that they are equivalent from a tracing perspective to a traditional ceph if you've created them properly. So they're just as good. You just have to have the software to do it. On that note, if you have the scan data, you can many times, and a software that won't do it, you can move it to that data to another software which will do it. I have no affiliations with any or financial relationships with any software companies, but I'll share that our orthodontic clinic at the university uses Dolphin imaging, and they reconstruct their lateral cephs with that. Okay, next question. Does the coronal mean that I'm looking directly at the patient? Yes, so by convention, coronal is you are looking at the patient as if you're staring them in the face. And you're just taking a selected slice in that patient orientation, more towards the anterior or more towards the posterior. And if you're looking at a cone beam CT scan or even a MRI or medical CT scan, you can look for the R and left or right and left tags to keep yourself oriented in that manner. Next question. Is there a cone beam CT that can render all the different fields of view? For example, if the machine can do a large field of view, can it do a small and vice versa? Or do you need to buy different machines or accessories? And this is coming from an office which has endo, surgery, ortho, and general at our office. I'm aware of a couple that will go all the way from a small kind of 5 centimeter cylinder all the way up to a large field of view. The majority of units typically don't. There's some small specific ones out there, and then some combo, a small and a medium, and then large. So there's kind of a division right in the middle. So my best recommendation is if you're looking for a unit that will do a number of different fields of views, get online and try and find some, but also speak to other practitioners in kind of your region and see what they have and what they like. Start talking with reps, because while field of view is a common starting point and where I say you need to start with deciding on a unit, technical support, software integration, image quality, and on top of software integration, workflow integration with the rest of your imaging software. If you're doing implants, any sort of implant software are really, really important. So you have to look at all of those in aggregate. It's a process to find the right one. And so consider all, don't consider a unit out, or don't consider 2 units if you're thinking you really need 1 unit to do it all. I don't know if I said that right. Don't be afraid of buying 2 units. Right? If you find that the one jack of all trade units for other reasons doesn't meet your needs. Is there any online? I think that's referring to recording of this. We're going to try and have it recorded, but we're also trying to get these webinars up off the ground. So I'll defer back to Joe on that one. And I think she and I are going to work together to hopefully have some of this recorded for you in the next coming months. Next question, can we control the voxel size, or most of machines control it? If yes, what is the best for implant placement? Okay, yes, you can control the voxel size. Different software or cone beams, like integration softwares, I'm losing my question, here we go, have different ways of approaching this. Some it's a little more automated. You might pick a kind of a scan setting where the voxel size is actually semi-hidden and it kind of sets it for you. But you are typically able to go in and change it manually. So, I mean, I feel like I'm not answering your question very well here. It really ultimately depends on the software. That being said, any given machine, there is a way to manage it somehow. Whether that's through a semi-automatic protocol you kind of set up once, or you actually manually select. For example, our iCat machine, we can manually select the resolution, or we can set up automatic protocol, both, and our techs will use both in different clinical situations. For implant planning, we'll discuss this more next week as well. Most voxel sizes are 0.15 to maybe up to 0.3. And I'll build on that discussion a little bit. The things you need to consider is, are you going to do this just quick alveolar measurement and you just need to see where bone and some, the canal space, some critical anatomy is, or are you actually doing a guided surgery where you need a little cleaner scan? And you can also incorporate the technical recommendations from whatever guided surgery protocol you're working with. Very good. Next question, what amount of radiation per lifetime from dental x-rays are at risk of cancer from x-rayation? Okay, because I learned that 1 mammogram is equal to 10,000 dental x-rays. Is that true? Oh boy. I'd have to look at the specific mammogram unit and the exact numbers there to answer your specific question. In terms of the first part, see if I can interpret your question correctly. Answering kind of broadly, any source or the most conservative and in my opinion, based on quite a bit of evidence, the most prudent assumption is that any source of X-ray radiation has a risk tied to it. So if you just had one single periapical radiograph, there is a cancer risk tied to that, and it doesn't go away. It stays with you for the rest of your life for the most part. Now we could dive into a couple day-long course about the timing of that, and in reality, it's a few decades. And so if you have a very elderly patient in their 80s, 90s, their risk consideration for cancers later in life becomes a little different because statistically then they don't have as many years as a young patient would left on with them. But the best assumption is that any small amount of X-ray radiation does have a risk for it. The smaller the radiation dose, the smaller the risk. And again, to kind of look at your second part of your question here, whether a mammogram equals 10,000 dental X-rays really probably depends on the specific mammogram technology and the specific dental X-ray technology, both of which have changed quite a bit in the last 5 to 10 years. And in both directions, doses have gone down. So I really can't answer that exactly without looking at the specific numbers. Can we see the pie chart again for dose? Yeah, I'll go back for that. Here we go. This is the pie chart right here. So again, the key point here is, and again, this is for the average American citizen. So if you have, that's the average number of CTs per person. Now, if I had 0 CTs, this part of the pie for me is gone. I want you to understand that about this graph. It's kind of easiest functionally to look at averages for a discussion like this. Radon depends on where you live. All right. The key point here is dentistry is a minor player. But again, even though we're a minor player, we still have some risk considerations to consider with. Next question is, by decreasing image quality, is there a possibility to miss a medical or dental condition such as lesions? Yes, there is. But that ties into whether we are screening that patient for incidental or surprise pathology, or we are taking a scan for a specific indication. And we'll build on that discussion slightly next week. But to answer this question right here is, for every scan or any image in a dental office, you have to have a reason to take that. It might be implant planning. It might be orthodontic planning. It might be an endodontic problem. It might be pathology. Each one of those might have a slightly different image quality concern. So you match the image quality to what you expect you're going to find based on that specific scenario. Now, if there's a surprise finding, you may elect to go back and do some additional imaging to get more information or more detail. And we could kind of discuss that at a different time. But what the opposite end of that approach is, we want to image every patient as high resolution possible, as large a field as possible, to capture every single piece of pathology we can. That's called screening, where you're looking for things whether you know they're there or you suspect they're there or not clinically. The data on that is for dental lesions, with the exception possibly of caries, which we kind of do a risk-based screening assessment. The benefits, the number of lesions you actually find is very low by taking that sort of kind of high-powered imaging approach. And we don't need to do it. It's not worth it in terms of how much dose cost, financial cost, time cost, any sort of measure for those patients. So I really stick to, you have a reason to take the scan, you match the image quality to it and go from there. PSP is phosphor plate, right? Yes, absolutely. And apologies if I skipped right through that. Those are the little flexible things that you take the digital image on and you run through the scanner, and they're supposed to last forever, but they don't. And they're annoyingly expensive to replace, not as expensive direct digital sensors. But that's what we're talking about there. Sorry for my additional commentary. Can you send us your presentation? Yes, I'm going to work with Joe, hopefully to have this recorded for you so you can review, and I think that'd be most useful with my narrative. On that note, just give us a few weeks, a couple months to get through our kind of our webinar series, as all of us have slowed down here in our normal daily lives, and we'll hopefully get back to you. What is your opinion about the recall follow-ups for bite wings for diagnostic or treatment purpose? Okay. So my assumption here is this is talking about ordering bite wings for primarily caries detection. My recommendation is to web search ADA radiographic selection criteria. So American Dental Association radiographic imaging selection criteria, and read it. It's a handful of pages. It's quick. And if you're really in a hurry, find the one table on that document, and it will outline a recall, an indicated or recommended recall schedule for bite wings specifically for caries detection. And without diving into a ton of details on that, what it's getting at is you do a risk assessment for your patient, and based on that risk assessment, they recommend recall bite wings at a certain time interval. That might be 3 months, it might be 6 months, it might be longer, 12 months, for example. And that's a major component of kind of recall imaging we use in dentistry. If you read through the rest of that document, you'll find that there's a lot leaned on clinical findings and professional judgment. So the workflow again is you have something you found clinically or something you want to achieve clinically, and the image specifically for that. Next question. Thank you so much for the great presentation. You're very welcome. Thanks for joining me on this evening. All right. Oh, my questions are jumping around here. What were the two upper lateral pontics made of? Are those natural tooth pontics? Oh, on this scan right here. I'll go back to it. I think you're referring to, nope, it's way at the front. This scan right here, I'm assuming, missing 7 and 10. This was a scan taken with a radiographic guide. So the patient was wearing essentially a flipper or interim partial with 2 radiopaque pontic or stent teeth. And the whole intent, do I have that slide? I don't think I have slices for it, but what you can do then if you're doing an implant planning, which this patient was set up for, is reconstruct the slices or the pan and cut right through these edentulous 7 and 10 sites and see on the imaging exactly where you wanted that tooth. So this is basically a virtual wax up, and then you can relate surgically where you want to put that implant to the desired prosthetic goal, which is where the tooth needs to go. What software are you using in this presentation? Most of the radiographic images were from a software called Anatomage, which is also it's by a company In Vivo. Sorry, the company is Anatomage and the software is called In Vivo Dental. If you have an iCat unit that you've bought in recent years, it's going to come with TX Studio or Treatment Studio, based on how you pronounce it. And it's going to look just like this. And really what iCat did, or Imaging Sciences did, is contract with Anatomage to use their software guts with the iCat name on it, basically. Like I said, I have no financial relationships with any software company. Anatomage is what I use for a lot of presentations and some interpretations, but on any given day, there's about half a dozen or more different softwares I use for different indications. Any recommendations on a cone beam CT machine or a software that you would use in general dental practice that focuses on cone beam CT being used for implants? Oh boy. I would start first, again, looking at field of view. And if you're looking specifically for implants, get probably a medium field of view unit. So something that'll do both arches. And that's anywhere from like an 8 by 8 centimeter or 10 by 10 centimeter. If you happen to do bigger implant surgeries, maybe get a larger field of view. If you happen to do more endodontics, maybe get one that also does a smaller field of view, 5 by 5 or something like that. In terms of what brand, there are many, many good cone beam CT brands out there. What I would ask is speak with reps, speak with your colleagues that you know, and see what they're using and what they're happy with. And where I would focus there in terms of software is I actually don't have a specific software recommendation. What I would recommend is decide, do you want to do just simple planning, and can I get by with a basic viewer that lets me reconstruct a pan and make some basic measurements? Or do I need to do more guided surgery planning? And if that, for example, I'll use Sirona as an example. They many times kind of have this integrated approach where you have the Sirona unit, the Sirona software. You can plan within their software and link it to some of their milling machines and have everything kind of integrated. There are some other software options. One of them is Blue Sky Bio, which is more kind of open source. I believe it's a free software to download. And from there, you can plan implants very nicely. And then you end up paying a fee to have a guide fabricated. And so your software choice really depends on what you need to do with the software. If you're in orthodontics, you need to do something that has more of the orthodontic tools. The software that I used for this presentation, Anatomage, is fairly expensive. It's several $1,000s at least for the full software package, but lets you do a number of fancy features, implant planning. You can use that to have guides fabricated for you, airway analysis, etc. So really, you get in the weeds very quickly based on what you need to do in your practice, and look at all the. Don't be afraid to look at all those details. Is there any use in measuring airway space in sleep apnea if the image is taken either in prone or supine position? Thanks for asking this question. So what on a cone beam CT and with a software that will do an airway measurement, you can actually get a nice airway volume or cross-sectional areas. In other words, the machine does a great job of providing that information. In terms of, is there value in taken either in the prone or supine position? It gets a little trickier. And so what I'll back up and say what we're trying to figure out is, do we have a patient who has, is at risk for sleep apnea and sleep breathing disorders? And can you see that on a cone beam CT? Well, the soft tissues in an apneic patient may look very different whether they're standing up or sitting up and awake versus lying down. They may look different if they're lying down and awake versus asleep, and they may look different if they are asleep and non-apneic or asleep and apneic. So there's a lot of variability, and even going back to the awake patient, just the position of their tongue, more anterior or posterior in the scan, can really throw off your volume and airway measurement. So keep all those variables in mind when you start to look at an airway dimension and account for that clinically. Now, it's not to say it's not a useful tool. You just have to use it properly and understand its limitations. Personally, I will look and I have a kind of a threshold where if an airway appears significantly constricted, specifically in the lateral dimensions, I will note that as a possible risk factor for sleep apnea. It is not a diagnosis of them having sleep apnea. And ultimately, that diagnosis comes from a true sleep study. Okay, next question. What are the main points needed when request the CBCT prescription? I can answer this question very generally and just describe what you think is going on with the patient, and where and what you want to do. All right. So if it's a piece of pathology, tell basically ordering a radiograph or home beam CT, where you think the pathology is, and what you think it is, and then describe some symptoms with it, kind of your clinical information. A good imaging clinic should be able to account for that and order a scan appropriately. If you're doing something else like planning an implant, of course, the implant site and any proposed kind of graft harvest sites or other surgical sites are really important to note. So basically that field of view, whether you're doing a guided surgery or not, or have any specific requirements based on your specific protocol, you can also put in, for example, if you need to be imaging at 0.2 resolution versus 0.3, all those decisions might be relevant. Okay, how much difference is between pano and cone beam? And I'm assuming that's dose. Pans in general, a traditional pan is lower than a cone beam CT, but not always significantly lower. And I can go back to the dose table right here. From an interpretation perspective, it's quite a bit different. There's a lot more data to review and wade through in the cone beam CT than the pan. All right, but again, pans 9 to 24 for dose versus cone beam CT. You're just getting to the low end of that here, 16 on to quite a bit more. All right, I've just got a couple. Let's see here. We'll see if we can get a few more questions. Into that. Okay. The patient comes in with a radiating pain coming from a quadrant and not a specific tooth to rule out possible cracked tooth syndrome. What field of view would you recommend using a cone beam CT? As small as possible and high resolution as possible. So if you're trying to find a crack, that's a research interest of mine. The sad truth is that based on available technology right now, you still won't see all the cracks, but occasionally we get a few clues that there's a crack or root fracture going on. Okay. Can you use a cone beam CT scan to help diagnose perio problems like infrabony pockets? Yes, absolutely. If you have a specific treatment need to look at the morphology of a specific pocket or crestal bone defect, the cone beam CT can help. Where it gets a little tricky is if there's metallic artifact that blasts through, streak artifact, if you will, that blasts through the crest. In that sense, you can supplement with clinical probing or vertical bite wings to get kind of the whole picture. For a young child that can't tolerate a bite wing x-ray, is it preferable to use a panoramic or a CBCT bite wing? Great question. I would go with the extraoral bite wing in that particular case, simply because it might be a little quicker than the cone beam CT. The cone beam CT is, unless you have a specific reason to be looking for that a pathology, for example, or a reason, the cone beam CT is typically a lot more dose than we may need for caries, for example, and even then, caries is hard to find. Small caries is hard to find on cone beam CT. And the highest resolution from Dr. Gavino. I hope you're doing well, Dr. Gavino. What is the thinnest accessory canal? Let's see. Oh, my questions keep jumping around. Sorry about that. What is the thinnest accessory canal? Does the CBCD, we can see in a measurement. Ooh. I'd have to look up, and I don't have the available numbers right now. Um, I do know there are accessory canals that are much thinner than a cone beam CT can see, to answer your question in a qualitative way. In terms of a measurement, you're not going to get, in theory, better than the nominal or best resolution of the cone beam CT. So that might be 0.07 millimeters as a minimum. We really can't, in theory, get any better than that. Is it appropriate to take CT images at a comprehensive exam on new patients? Probably not at this point in time from a dose and diagnostic perspective. And again, if you review that um, ADA, radiographic image selection criteria, it doesn't discuss cone beam CT at length all that much, but it'll discuss in new patient imaging, and their recommendation at this time is if it's a simple patient, a pan and bite wings, and selected periapicals based on teeth that might have, like, tooth of the crown, you might order a periapical just to evaluate the periapical bone. That'd be for a simple patient. For a patient with complex dental presentation, or you're just seeing a lot of clinical disease, a full mouth series, that's the route the ADA takes right now. For the most part, cone beam CT at this time is thought to be too much dose with not enough diagnostic yield. 20 years or even 10 years from now, we might look back at and be imaging in 3D as doses go down. But the recommendation from the ADA is what it is right now. You're welcome for the pie chart. All right. Oh, great. We have a mammogram dose is approximately 0.4 millisieverts. All right. And again, the units we were looking at were microsieverts. So those who are interested in that can do the math. Okay. Would it be possible to pull bite wing off recreated panorex for a patient with strong defects that good quality bite wings have not been able to obtain? Okay. Not from a cone beam CT. The resolution isn't there. But what might be acceptable would be extra oral bite wings if you have a unit that manages those or acquires those. The available data on extra oral bite wings for caries, again, you don't have to put anything in the patient's mouth, it kind of feels and acts like a pan, is they're pretty darn good at picking up caries. What you have to be careful for is a superimposition from the ramus and the mandible from the other side, creating kind of a radiolucent line that if it's in the right spot, it can look like caries. So it creates what we call a false positive. So once you learn to recognize those artifacts, you're probably good. And I do believe that if you have a patient that just cannot tolerate intraoral radiographs, the extraoral bite wings are your next step. Cone beam CT is too much. And again, the resolution there for small kind of incipient caries detection isn't quite good enough. Is it reasonable to use cone beam CT as a screening tool without evidence of disease? In other words, in search of occult disease? I think we covered this prior. And again, the answer is really no. We're not screening with kind of this more advanced imaging tool at this time. The yield is not worth the dose. Okay. Here we go. Hopefully, again, my questions jumped around just a little bit. So in relation to dose, I'm a hygienist and we do full mouth series and PANA for all adult new patients every 3 to 5 years, depending on the caries pathology rate. Would you say this is standard? The base textbook answer to your question is there really is, except for the ADA caries recall recommendations, there is no standard, there is no routine radiograph from the strictest, most textbook term. So you really need to look at that ADA imaging selection criteria. And once you get your baseline For the most part, that document outlines clinical imaging or clinical finding-based imaging only. So if you have something new that shows up clinically for your existing patient, you take the specific images they need. That might be a pan, that might be another full mouse series, that might be just a single periapical. So it really depends on clinical judgment. Great lecture. Okay, thank you. Yeah, great to hear from you. Thanks for coming. Okay, let's see. Do you have any idea what percentage of general dentist DDS practices have cone beam CT units? I don't right now. I've tried to get that information and uh, don't have it at hand right now. It's a moving target. What I can say is that cone beam CT is here to stay for a while. It's just become too integral to many different practices and specialty areas of dentistry to go away. So that's why I really advocate for, even if you don't have one in your office, be comfortable opening one up and working through it. And we can build on that discussion next week. Is the CT required for a particular special case, or can it be taken for every dental procedure? Again, on this one, I think it really depends on the specific scenario. We're not yet to the point, and it's overkill from a dose perspective, to be acquiring a cone beam CT on every single patient out there. All right, when a patient brings in a CT scan from another office, are we able to duplicate that CT scan for our records? Absolutely. And my blunt recommendation would be to just copy the files onto a secured space in whatever kind of network or computer system you have. For the most part, if you can find the DICOM files, or basically something that has one folder with several hundred files or one big file, that's the data itself. And hopefully you have a separate software that might be able to open up and view that. If the patient brings in a CT scan from another office and everything's on that disk, for the most part, there's a couple exceptions, but for the most part, you can copy all of those files into a separate folder and be able to open it up later. There's some nuance around that. So again, if you're going to try and do that, experiment. Don't be afraid to copy and see if you can move things. As always, it's patient information, so it has to be handled securely. All right. Legally interesting that you can't make a copy. I'm not terribly familiar on that perspective. I do know that keeping records is a valid part of our practice at the U. All right, I think that's the end of our questions.